Hello and welcome back. The previous podcast in this series on responsible psychotropic prescribing looked at issues related to when and what medications to prescribe to adults with an intellectual disability. This follow-on podcast will cover practical issues relating to instituting, monitoring and discontinuing psychotropic treatment. Before commencing medication, it's very important to develop a treatment plan in collaboration with the person with an intellectual disability and, where relevant, their carers and other service providers. This treatment plan should detail the person's communication needs, the targeted behaviours or symptoms that the medication is intended to treat, and the current frequency and intensity of these symptoms. What method you have put in place to measure the impact of medications on these behaviours or symptoms. How frequently and what method you will use to measure adverse effects associated with the medication. The treatment plan should also summarise all previous assessments of medical, psychiatric and functional causes of the behaviour or symptom and past responses to treatment, including adverse effects. A treatment timeline and contingency plan if the medication proves to be ineffective should also be agreed upon before starting the medication. Make sure you obtain consent for treatment from the individual or an appointed decision maker, and make sure that the patient understands as fully as possible what is being prescribed, possible side effects, and so on. When commencing psychotropic medication in this population, it's important to start on a low dose and increase slowly if needed. This is because people with an intellectual disability are in general more vulnerable to the adverse side effects of psychotropic medications. During treatment, make sure that the patient and their support network are educated and involved in the monitoring process. Communication with formal and informal carers is essential. Formal and informal carers often play a central role in monitoring and communicating drug-associated behavioural changes to medical practitioners. People with an intellectual disability may have difficulty recognising or communicating psychotropic side effects. Sudden behavioural changes after starting or increasing psychotropic medications may indicate adverse effects. For example, abrupt onset of pacing or fidgeting may be a behavioural manifestation of antipsychotic-induced akathisia. Increased agitation may also represent a paradoxical reaction to a benzodiazepine, or may indicate an adverse effect, such as constipation. Monitoring medication side effects in people with an intellectual disability requires a holistic and multidisciplinary approach. Health professionals that could be engaged to support doctors and psychiatrists during monitoring, including physiotherapists, exercise physiologists, dietitians, diabetes educators, endocrinologists, mental health nurses and psychologists. Potential barriers to effective monitoring, such as communication difficulties and fear of blood tests, should be worked through very carefully. In the previous podcast, we discussed the importance of considering physical comorbidities when prescribing psychotropic medication to a person with an intellectual disability. It's important to monitor any effects that the selected medication may have on pre-existing medical comorbidities, including cardiometabolic disturbances. 3DN have developed an early intervention framework to support clinicians to monitor cardiometabolic side effects in patients with intellectual disability who are prescribed psychotropic medication. This resource is available on the 3DN website. Tailored educational materials about psychotropic medications for clinicians, people with an intellectual disability and their carers are also freely available from the 3DN site. To further explore medication side effects, Dr. Bruce Chenoweth will now discuss the case study of a non-verbal adult with intellectual disability and the serious side effects from their medication.
I'm going to introduce Michael, moderate to severe intellectual disability and autism. He was institutionalised at the age of 19, and it was in one of the large residentials that I first met him. He has a very caring and very involved family, who really were unable to manage him at home because of his behaviour and because of his idiosyncrasies. When he was first assessed by a psychiatrist in 1994, he was deemed to be not only physically fit, but he was pretty actively engaged in all activities within the large residential complex, and was verbal and would signify his needs quite adequately. However, at the age of 32, a functional decline began. He began self-isolating within that context. He started to lose self-care skills. He was apparently responding to external stimuli. As part of this, he would suddenly lash out at staff and at residents that stopped eating, and there was a reversal of his day-night rhythms. I was first asked to see him in the mid-1990s when it was quite apparent that he spent much of his time terrified. One might think that it was appropriate to be terrified. You know, those institutions were fairly rough places way back when. But in his case, the care had been exemplary. He had caring staff. He was considered part of the community there. Tentatively, and with all the difficulties inherent, we thought that he was developing a psychosis, and he was initially placed on thiridazine. In 1996, he was moved to risperidone in quite low doses, 1 milligram twice a day, which gradually escalated to 2 milligrams twice a day. He developed extrapyramidal side effects, including a neck dystonia, which was quite marked, a dysphagia, unable to swallow, which, interestingly enough, is one of the first of the extrapyramidal side effects that we see in moderate to severely disabled patients. He developed a mild Parkinsonian tremor, and he also developed restless legs, akathisia. He was subsequently changed. The risperidone was reduced and with no benefit, and he was changed to olanzapine in late 1998, 5 milligrams twice daily. This didn't hold the psychosis, but did not seem to be causing, initially at least, any extrapyramidal side effects. It became obvious that we had a balancing act here. The efficacy of the medication against his psychosis versus the extrapyramidal side effects. Much juggling of doses and different antipsychotics then went on for many years. Withholding antipsychotics led to a worsening of his psychosis and subsequent terror. In 2006, the first episode of serious ataxia, sialorrhea, that's dribbling, muscle rigidity, dystonia, dysphagia, unstable blood pressure, and subacute delirium occurred. His creatinine kinase levels became very high, and there were other parameters of an increased immune response and proteinuria, but no pyrexia. He was admitted to the neurology ward and taken off all antipsychotics. A neuroleptic malignant syndrome was not confirmed by the neurologist. He returned to his home unit and, after 2 months off all antipsychotics, became psychotic. He was re-challenged with olanzapine at low dose, 2.5 milligrams BD. We did weekly creatinine kinase levels for 3 months, then monthly. His blood pressure, pulse rate, temperature, and respirations were recorded and monitored daily. The dose of olanzapine fluctuated with his clinical state. When we achieved doses beyond 5 milligrams BD, the extrapyramidal side effects would begin. Other drugs tried, which also caused EPSEs, included lithium, carbamazepine, and sodium valproate. After 2012, he developed severe chorioathetoid movements. Rapid cessation of the olanzapine led to even a worse rebound of akathisia and tardive dyskinesia. The severe movement disorder was treated with tetrabenazine and diazepam. The investigations that we performed included a very comprehensive genetic review. He would fit the bill for Huntington's disease, in as much as 40% of those with Huntington's will present with a psychosis at the age of 40 or above, approximately. He did at 35. And there has been this slow decline in the development of, in his functional capacity and the development of chorioathetoid movements. But he doesn't have Huntington's disease. There is some neurodegenerative process going on that we do not understand. Is it an autoimmune encephalopathy? The HSV1, the anti-NMDAR antibodies were negative, as were the anti-thyroid antibodies. Routine creatinine kinase, LFTs, full bloods, ESR, C-reactive proteins, electrolytes and urea continue to be done, with only the former, the CK, fluctuating, largely because of the muscular activity that continues. TPR and BP checks are done daily. In discussion, people with intellectual disability can be exquisitely sensitive to psychotropic drugs and side effects. Side effects may be prolonged or semi-permanent, particularly after discontinuation. The rule is that we start very low and go slow. A very slow withdrawal of antipsychotic medication is necessary if postsynaptic receptor proliferation is suspected. Finally, I'd like to quote the great guru of psychopharmacology, Stephen Stahl. If a drug is powerful enough to do what you want it to do, to be efficacious, it's also powerful enough to cause you great grief. I thank you.
As with the general population, discontinuation of psychotropic medication should be regularly considered and trialled if the medication is not effective, produces unacceptable side effects, or is no longer needed. Medication should be tapered slowly whenever possible to decrease the risk of discontinuation syndromes. Be aware that discontinuation may be more difficult when the person has been prescribed high psychotropic doses over long time periods, or when the patient has a high pre-existing level of challenging behaviour. Thank you for listening to this podcast on responsible psychotropic prescribing for adults with an intellectual disability. The next and final podcast in this series will explore how you can help people with an intellectual disability stay healthy from a consumer perspective. We hope that you can join us.